Hello, everybody. So good to see you all. We're excited to have you with us today for our program. My name is Anissa Mitchell with PMD Alliance. And before I introduce our speaker and our topic, I want to introduce the concept of chatting your questions. So most of you already are experts at this. So if you would just pop up your chat box, that's where you're going to ask your questions today. And we're going to hold the questions until the end of the discussion, but feel free to ask those questions and also give us a shout out and let us know where you're joining from, because we get people from all across the country and even some of our international folks joining us. We just like to know where you're joining from. And I'm going to introduce our speaker. So with us today is Dr. Brent Bluett, and he is a movement disorder specialist in California. He's going to be talking to us about botulinum toxin, which is a mouthful, and its uses in movement disorders. So I need to put out a little disclaimer because we often use the word Botox, short for botulinum toxin. And it's Botox is actually a trade name form of botulinum toxin. So we even did that in our emails to you. So I just want to let you know that when we talk about botulinum toxins today, we're talking about all different forms and all different indications for those, not the actual botulinum toxin medication itself. So it was sort of our shorthand version I think we've all gotten accustomed to using. So just wanted to clarify that before we get started. So now I'm going to push this over to Dr. Bluett and let him take over, and he's going to give us all this great information on how we can use botulinum toxin.
Great. Thank you so much, Anissa. It's a pleasure to see all of you. I really appreciate it. And I'm going to jump right in and share my screen here so you can see the PowerPoint. Does that look good, Anissa? And is it good?
It is. It's still in. I can see the other slides on the side. There you go.
Okay.
Perfect.
Great. So thank you so much, everybody, for coming. I see a large group of people here. I was scanning the videos and seeing who I can inject while I was looking at the participants. Not for cosmetic reasons, you're all beautiful, but that's what we're here to discuss is the indications for serious medical conditions for botulinum toxin. And Anissa justly said that there's different formulations. We'll discuss all of that. Botulinum toxin has really been a miracle. And when I first started injecting, I first of all do not like needles. I cannot stand getting my blood drawn or getting COVID flu shots, whatever. But I ended up doing it and found after the first time I did it was for migraines. So I would inject, we would inject a lot of people, about 20 people in a half day, myself and my attending during fellowship. And at first it's 31 injections, and I thought, this is cruel, this is terrible. I see blood coming out, this will, a little bit, and this is terrible. And then the people who had headaches for months and months and years and decades came back and said, my headaches are gone and or significantly improved, and I never thought this could happen. So I just became a believer, got more into it, and found that there's just lots of uses. So we'll discuss. All right, so the title of today's talk is Botulinum Toxin Injection for Movement Disorders. My name is Brent Bluett. I am opening a new business, Central California Movement Disorders in Pismo Beach, California. For those not familiar with the area, it's near San Luis Obispo in Central California. This talk is for the PMD Alliance. Today's date, February 2nd, 2022. So botulinum toxin is derived from a bacteria called Clostridium botulinum. Now, ingestion of BONT or botulinum toxin by dirt or contaminated food can cause botulism. This can result in a very serious condition which causes ascending paralysis, even respiratory failure. However, we've figured out a way to formulate this toxin in extremely small doses as a very safe and effective method of relaxing overactive muscles or glands. It's administered via injection. Again, I don't like needles, but it really is painless if done right, relatively painless. The needle is very small, and it's very important, honestly, and this is not a self-advertisement in all sincerity, that comes later. But you need an expert. I've seen people go to other physicians who are maybe not as well versed, and that's when you get adverse effects, and we'll talk about that too. So botulinum toxin is typically known for its use in cosmetics. It reduces wrinkles by relaxing facial muscles. However, it first received FDA approval in 1989 for medical conditions such as blepharospasm, hemifacial spasm, and strabismus. Blepharospasm is excessive blinking. Hemifacial spasm is one side of the face movements. Strabismus is lazy eye. Do not do those injections anyway. It is now commonly used for a wide variety of medical conditions, including overactive bladder, hyperhidrosis is sweating, migraine headaches, spasticity, laryngeal spasm, many, many, many more. How many more? Well, Time magazine came up with an article, this is in 2016. They're using off-label indications now for over 793 different medical conditions for botulinum toxin. And interestingly, Anissa accurately stated it's not just Botox, it's botulinum toxin. So this article was a bit inaccurate and not comprehensive. But there are a number of indications for botulinum toxin. And really, you think about anything that's overactive, that's basically what botulinum toxin can improve. So what happens is the injections are temporarily used to relax injected muscles. They're cleaving key proteins required for nerve activation. What it does, it binds specifically to nerves. They use the neurotransmitter acetylcholine. Acetylcholine goes from the end of a neuromuscular junction to the other side, activates the intended target organ, which is a muscle or a gland. This clings on to the one of the proteins that accepts the acetylcholine and stops it from accepting it, and therefore the muscle or gland is not activated. So in large doses, it can cause paralysis, but in the very extreme small doses we use, it just causes relaxation. I basically call it a chemical massage. Now, the effects typically take 4 to 10 days before you start to notice improvement. The improvement is very gradual, so therefore the effects can be subtle. Oftentimes when I talk to people, I ask every person, how long did it take before it started to work? When was the peak? How much better did it get at the peak? And when did it wear off? And were there any complications? Those are the 5 questions I will ask with every visit. And most people will, the first time will say, for non-obvious reasons, non-obvious things like cervical dystonia, where there's a head tilt or neck pain, I am not sure when it started to work. And then I'll ask more questions. So are you able to turn your head now? Oh, I don't know. Okay, let's go. When you're in the car, can you look back now and see the cars behind you? Yes. Are you using less than 2 pillows at night to sleep? Yes, I'm actually using 1 now. And so it's a subtle, gradual effect. It may not be so obvious like a surgery, but in a way that's a good thing. The peak benefit can occur anywhere from 2 to 8 weeks after the injections. The effect tends to wear off after 8 to 12 weeks, and therefore we do the injections every 3 months, and therefore insurance typically approves only 4 injections a year. The injections are easy to administer with few side effects, honestly, and this is, again, if done properly by an experienced physician. We sometimes use an EMG, an electromyogram, and that's basically detects electrical signals from muscles when they're actively contracting. So when you put the needle in, you can hear this noise, and it tells you which muscles are overactive, which can guide the injections. This is an example of an EMG. It's a small device that we use. Now, for the kinds of different botulinum toxin, there are currently 4 different types. There's type A and type B. These are the 4 types that are available currently in the United States. There is, and they're a mouthful, botulinum toxin, Botox, A. Excuse me, botulinum toxin A is Dysport. Botulinum toxin A is Xeomin. And there is 1 type of botulinum toxin B, botulinum toxin B or Myoblock. Now, this is the American Academy of Neurology. Back in 2016, they came up with a list of the different botulinum toxins and what their indications are. Level A is obviously top efficacy. B is good, but not as great as A. C is mediocre. U is insufficient, etc. These guidelines are quite honestly not typically followed. We typically usually start off with Botox on a botulinum toxin A, quite honestly. That is the most widely available. And it usually has as good of efficacy as the other types, as same basically side effects. We'll discuss that a little bit more. Now, in movement disorders, there are numerous different conditions you can use this for. I do not inject for all of these conditions. I'll go through and tell you typically what we inject for. Spasticity, definitely. I've seen patients with stroke who have come in and literally had their fingers curled into a ball because of the stroke. One poor gentleman had fingernails growing into his palms, and he couldn't cut his nails because his hand was gripped so tight. So you inject the forearm, it relaxes the muscles in the hand and fingers so the fingers can relax, open up, and he was able to finally cut his nails, which is just, necessary. Blepharospasm, excessive blinking, we'll talk about that. I do inject for that. Oromandibular dystonia is jaw clenching, yes. Bruxism, yes, the same thing. Laryngeal dystonia, no, that's clenching of the larynx. Cervical dystonia is abnormal involuntary movements of the neck. We'll talk about that. Very common in Parkinson's, very common with essential tremor. Yes, I do inject for that. Limb dystonia, definitely. That's usually inward turning of the foot. And again, I'll go through all this again. So I know I'm talking a little bit fast. Hemifacial spasm, unilateral facial contractions, definitely do inject for this. Tremors, not so much, except for head tremors. There's off-label use for Botox injection for hand tremors, but the problem is it can cause weakness. And really to get to an effective outcome, you have to inject high doses, and there are higher risks of side effects as the higher doses. We'll talk about that too. Tics, myoclonus, not so much. Restless leg syndrome, not so much. Typically not injected for those, but the other ones definitely, those are very standard practice for all movement disorder specialists. Now, the FDA approved indications specifically in movement disorders are 1, sialorrhea. 10 to 20% of Parkinson's disease patients have this. This is excessive salivation or drooling. Essential tremor, 90% of patients with essential tremor have a benign head tremor or cervical dystonia. I get irritatingly excited when I see somebody with a head tremor because I know they've been suffering for years, and I know that I can help them, and that they didn't know about this. This is the reason for this talk, is to spread awareness for this, and there is treatment and help for these conditions. Dystonia is in 30% of Parkinson's disease patients. This can involve the neck, cervical, focal limb, as we talked about before, typically the lower extremity or leg. Blepharospasm, apraxia of eyelid opening, typically seen more in atypical Parkinsonian disorders or Parkinsonisms. But this is basically excessive blinking. Apraxia of eyelid opening is difficulty using the eyelids. We'll discuss that later. Dystonic tremor, as before, with the head. Oromandibular dystonia, jaw clenching, definitely helps with that. And as we discussed before, spasticity of the upper and lower limbs. So in Parkinson's disease, here's a kind of a list. You can see all the different indications. I mean, this can be used for anything. So again, the blepharospasm, lid apraxia, bruxism, the dystonias. Camptocormia is a very extremely flexed posture when you see somebody almost looking at the floor when they're walking. It's common in Parkinson's, and Botox can help with it. It's difficult though. You have to inject large doses, and it's difficult, but it can help. Jaw tremors can be used. Freezing of gait, there's exploratory information regarding Botox, but it doesn't have a good level of efficacy yet. I do not inject for freezing of gait. There's other mechanisms to treat this. Sialorrhea is just, it's the easiest treatment I've done in all of medicine. We'll talk about it more, but the injections it's 2 pokes into the cheeks. It takes no time at all. It's easy. I've literally never had one side effect, and I think I've done at least 1,000 injections for it. Overactive bladder, I do not, but urologists do it, and they're more effective at that. You need an ultrasound guided to find the bladder, so I don't do that. Most movement disorder specialists do not, but it can help. Constipation is completely off-label, and there's other ways to remedy this without using a needle. So we'll go through the different indications. For sialorrhea, this is drooling or excessive salivation, can be embarrassing and bothersome, sometimes even dangerous. You can treat this with medications. So this is typically used glycopyrrolates, or also called Robenal, but this medication is anticholinergic, so therefore can cause imbalance, fatigue, confusion, dry mouth, urinary retention, constipation. This is a small list of the side effects. There are many more. So it's a choice you have. Remember, in medicine, everything is your choice as the patient. It is not the doctor's choice. It is your choice. It is your body. Okay. So you can think of it two ways. What would you rather do? If you're drooling and you want to stop it, would you want to take a pill every day that can cause side effects? Not always, but can. Or just get 2 pokes in your cheek once every 3 months. That will pretty much stop it completely. Of these different types of botulinum toxins, Myablock, the type B formulation, is typically the most effective. However, it's acidic and therefore it burns when it's injected. So I typically just use botulinum toxin A or Botox, but again, this varies among providers. So all 4 formulations of the BONT are used for this condition. Potential side effects of this, as you can see, are very, very, very low and minimal. Increased saliva thickness, 4%, makes sense. Dysphagia, I've never had one patient with this. And you're going to see here, I'm going to go through this in general, and I talk about this in a slide. The list and the percentage of side effects that are listed here are much higher than I've seen in my practice. And that sounds arrogant, but I think it's true. You'll see, we'll go through a little bit more. Xerostomia is dry mouth, makes sense. If you get injections and there's too high of a dose, then you get a little bit of dry mouth, and water can cure that. Pneumonia, I've never had this happen or seen or heard of it as ever happening. But again, these are reported on everything ever listed in clinical trials. And so it's very important to have all data. Cervical dystonia, this is probably the most common thing that I'll inject for. Dystonia is an intermittent, sustained, repetitive muscle contraction resulting in abnormal posture. Can either occur on the neck with cervical, neck stiffness, rigidity, tremor, limited range of motion, or can occur in the limb, causing arm or leg stiffness or rigidity with abnormal posturing. Now in Parkinson's, this typically, and some people are going to have an aha moment here. Limb dystonia is typically when you're lying in bed or your medication wears off, the carbidopa, levodopa, and your toes start to curl and they kind of hurt, and one foot will start to turn inwards and bend down. It's called plantar flexion and inversion. It's usually an off dystonia is what we call this. Off meaning off the medications causing dystonia, this cramping. It's very easy to treat with the Botox. Simple injections into the calf, not the bottom of the foot, which causes horrible pain. Just into the calf can solve this and basically resolve it. I've had, I'd say on average, 60 to 80% improvement with this. For medications can help, but side effects are common. There are various medications. I'll go through these for comprehensive sake. Trihexyphenidyl or Artane is effective, but again, it's anticholinergic, so it can cause a lot of side effects. Baclofen, very effective, but can cause lightheadedness when standing, sleepiness, a bunch of other symptoms. Clonazepam is a basically a controlled substance. Excuse me, this is typically indicated for panic attacks and also for sleep. But it basically, as it's a sedative, it relaxes any kind of hyperkinetic movements. All of these can cause sedation, imbalance, and confusion. The botulinum toxin injections are FDA approved for both the neck and for the limbs, and very effective, and they're very safe. And again, I'm going to keep recommending somebody with experience do these in your area. Just FYI, if you go to Botox at the Allergan website, they actually have a list of Botox injectors near you if you put in your zip code. And this is not an advertisement for them, but it's just to let you know, because I saw the variety of places people are coming from. So that might help you. I'll show you, this is definitely self-promotion. This is a video I did of injections for somebody in Las Vegas when I was at the Cleveland Clinic. And I was on, here we go.
We're not seeing the video.
Oh no.
It's still on your slide. You'll have to go up and change your share.
Oh, thank you so much. Okay.
Yeah, maybe because you're sharing the
Thank you, I
PowerPoint,
got it.
not the video.
Okay. How about now?
Yeah.
Thank you.
See, the volume is low.
Okay, I can't turn it up.
Okay.
Hmm. Hmm.
Give us commentary on what you're saying.
Yeah.
So we can hear you.
Sorry, guys. So for me, it's like super loud. Basically, what I'm doing is using the EMG. Her earrings are little target hoops for the muscle right there. And that's the sternocleidomastoid. You can see the injections themselves take about 5 minutes total. Very easy to do, safe. There's very few complications from them. This lovely lady, she had head tremor for years, as I was talking about before, and she didn't know that there was a treatment for it. And when the injections are effective, the head tremor goes away completely. And we'll talk about the on and off periods regarding this as well. But just wanted to show you a little bit more than sharing my own experience, but just to show you what it's like to get the injections. Okay, sorry about this. Hold on. I'm playing Where's My Mouse? Let's see here. Okay. Sorry, guys.
No worries, we're flexible.
Thank you. Let's see. Okay. It came back. There we go. All right. And is this good, everybody? Back on track here? Okay. So potential side effects for the cervical dystonia injections. This is the one I found very extremely high potential side effect risk. Dysphagia is difficulty swallowing. 19% of people in overall from the Allergan website. Upper respiratory infection. I've never had one person have this, but it's 12% listed. Neck pain, definitely, that can happen. This is needles. They're going into the neck. It can happen. There can be some pain there. Headache, never had this happen either. Those were the most common. What I've usually seen, the ones we're really concerned about is if you inject too much, that you can have a head drop, where the back of your head, the muscles become weakened and you're unable to hold your head up. That was what I saw in people who are not experienced injectors and what really scared me. And we'll talk about ways to avoid that. The other one is the dysphagia. That can happen, just not 19%. I've had this happen probably about, I would say overall 20 times in about 5,000 injections, which is about 2%, I think, or less than that. So it's very rare. Anyway, so eyelid dysfunction, what there is blepharospasm or apraxia of eyelid opening. Blepharospasm is excessive blinking involuntary of the eyelids. Apraxia of eyelid opening is an inability to voluntarily control eyelid opening or closure. And sometimes you have to use your hands actually to open your eyelids. Oral medications are less effective. Eyelid crutches may be a benefit, but the botulinum toxin injections are FDA approved and indicated for both indications. And potential side effects, you can have an eyelid ptosis, which is a drooping of the eyelid injected. You can see the numbers here. This is extremely high. I think I've had this happen twice of the injections I've done. Dry eye, never. That should not happen. Dry mouth, I don't know how that happens. I really don't. But I wanted to cover all these for comprehensive sake, because the scary thing is when you're about to get your injections and you go on the internet and you start reading, and this happens a million times, I've seen this over and over, and you think, oh my God, what am I doing? This is this potent biochemical terrorism weapon I'm injecting into my body. And there's so many, and it's really not dangerous. It's really safe. Again, if you have somebody who's very experienced, this should not be a problem. Hemifacial spasm, unilateral facial spasm caused by irritation or damage to the facial nerve, typically due to arterial compression. The way this begins, usually there's lower eyelid spasms. It progresses to involve the upper eyelid, then it can spread to involve half of the face. Oral medications are typically similar to those used for the blepharospasm. That's again, Artane and the other medications we talked about before. There is surgery that can reduce the arterial compression on the nerve. I've seen the surgery. I know the surgeon who did it. He's one of the best in the world, neurosurgeons, and he says it's the most difficult neurosurgery to do. And if you can avoid surgery, it's probably better too. So therefore, the BONT injections are FDA indicated for the treatment of hemifacial spasm. Potential side effects, these are a little bit more realistic. Ptosis, 8%, double vision, 1.6%, blurred vision, 2.5%, dry eyes, 2.5%, problem swallowing, which should not happen if you're injecting just the face, 5%. Facial droop, obviously that could happen, but that should not, 3 to 5%. Oromandibular dystonia or bruxism, very common. This is a focal dystonia affecting the jaw and face muscles. Some people have involuntary jaw opening, or the jaw remains shut, can't open. or there's lateral shifting. I've actually seen this so severely in somebody taking a medication causing this, that he chomped so hard that he was breaking his own teeth, and he could not stop, and it was horrible. And we injected and it reduced it significantly. Changing the medication ultimately was the treatment, but that this helped. Bruxism is very similar to oral mandibular dystonia, results in jaw clenching, typically during sleep. Both of these can cause headaches, damaged teeth, and or cause temporomandibular joint syndrome. Potential side effects, and I think this is definitely over, is dysphagia 10%, dysarthria 1%. Never had dysarthria. Dysphagia I've never had from this that I know of. You're injecting into the masseter, which is your side, a side of your face that if you clench down your teeth, you can feel it. Your masseter, and it's very obvious, very easy. And if you use a low dose, you should not have any side effects. Spasticity is an abnormal increase in muscle tone or stiffness of muscle that can impair function and cause severe pain. There are several conditions which can cause this: multiple sclerosis, stroke, traumatic brain injury, spinal cord injury, cerebral palsy. There are oral medications to treat this. They can cause sedation, fatigue, lightheadedness, and imbalance. But the Botox is FDA approved for upper head or limb spasticity. Potential side effects, again, it makes sense. Temporary weakness to the extremity if you over-inject can be less than 10%. Some injection site pain, less than 10%. And because you inject a larger amount for the limbs and for spasticity, there can be systemic side effects. That's when you can get flu-like symptoms, which do go away in 2 to 5 days. You can take ibuprofen, this resolves it. There can be fatigue and malaise. And again, these are side effects potentially, but they should not happen. So there is a chance that you can develop a resistance to Botox, but typically it's effective for decades. So the lack of response to the injections can occur due to the risk of neutralizing antibodies. So basically your body develops a response to the botulinum toxin over years or decades. This is the reason you cannot do the Botox too frequently. Some people ask, can I get the booster like they do for cosmetics? If you do that, you're increasing the risk of developing the neutralizing antibodies and then developing a resistance that will never work. Actually, it's not true. It won't work for that formulation. There's a way to switch this. If you have a resistance to one formulation of those 4, you can switch to a different formulation. So you have 4 different options. So technically, you really can't run out of reasons to give injections. There's some injectors who will test this. There's no antibody test specifically to look for these neutralizing antibodies. Some injectors will actually inject in the medial part of the eyebrow, and so and then when you frown, one side of the eyebrow will either relax and weaken and not be able to contract, or it will contract as it's supposed to. I don't want to cause a flaw in somebody for 3 months just to see if this works or not when you just switch formulations. So I don't feel the need to do that, but just FYI, that's something that you can do. Other things that can increase the risk of the antibodies and resistance: high doses, longer duration, higher risk of developing a resistance, and the high protein load. And they found that this is more in the type B, rheumatoid type B, than in type A studies, up to 42%. Takes decades though. So my personal experience is the incidence of side effects is much lower in practice than those listed above. Common sense with everything in medicine: start low, go slow. Don't overdo it on the first shot. Better to under than over inject. My first motto, obviously, as a physician, is do no harm. And so I don't want to cause problems. I want to treat the problem you come in with, not create new problems. If you do not obtain the desired effect with the first injections and there are no side effects, you can increase the injections with the second set to get more of the results that you want. But first, go safe and go slow. If there is no improvement by the third set of injections, it's probably time to not proceed with injections again. And you can try oral medications or another intervention. And some people, I will inject low doses, but also give a medication and use a combination of the two to get the desired response. Now, there's a new type of botulinum toxin A, botulinum toxin A, I do not make the names, that was recently evaluated in a phase 3 trial in cervical dystonia. This is for the neck. The study enrolled 301 patients from 60 sites, confirmed the findings. It is safe and effective. Phase 3 means it's pretty much ready to go. So this should be coming out in the next year or 2. Typically, we inject about 200 units, but for this, it was only 125 units, and it lasted twice as long as the other formulation. So this is very exciting. This will be good. Most people don't want to get poked in the neck frequently. So it's better to do it less frequently, and this is promising. There's another new type of botulinum toxin that is marketed chiefly in Asia called bland botulinum toxin A, and that probably will be coming our way at some point as well. This is, I definitely am promoting myself, I apologize, but I'm opening a new practice in Pismo Beach. It's called Central California Movement Disorders. It's dedicated to treating patients with movement disorders. I've worked at the Cleveland Clinic and at Stanford, and I came down here to really provide a treatment for this area, which is in need, and to help out the wonderful people here. I will offer the botulinum toxin injections for the above indications, and I have performed over 5,000 injections. If you're interested, you can call this number for an appointment. However, I see many people are not here in this area, and so I'd really recommend going to the Movement Disorder website, MDS, and to look for a provider near you. You want to have somebody who is an expert in movement disorders who can give you the injections. And as a general rule, if you're going to get injections for something, go with the experts. So if you're going to go for migraine injections, I can do them, but a headache person they're better. They do that every single day. For the overactive bladder, I wouldn't have movement disorder specialists. I have my urologist. Whatever the indication is, think about who the specialist would be. If it is for movement disorders, excessive blinking, for neck stiffness, pain, tremors, movement disorders, definitely. But ultimately, I just want to give you the best outcome possible. So that's it. I want to leave time for discussion, and I just want to thank all of you for coming, and I appreciate it.
Thank you. And we do have some questions, so I'm going to try to go back up. I've been trying to collect them. So you mentioned the lower limb dystonia earlier, and this person had asked early on, they said they have bad cramping in both calf muscles. Will this help that?
Yes, definitely. That's exactly what happens. And so there's a couple of reasons that can happen. If it's more of restless leg syndrome, the first thing to do is to check for iron and ferritin to see if that's causing the symptoms. Restless legs is when there's a sensation of relief when you stand up that relieves the irritation that happens when your legs are moving and causing these movements. If it's really truly an off dystonia, it'll be cramping of the toes and of the calf, and there'll be inward turning as well. And so there's more of a painful response with that. So if you have to get up and move and it's relieved, restless legs, check iron and ferritin. If it's just for the cramping, then yes, probably an off dystonia, then I would get Botox, botulinum toxin injections.
Great. You also mentioned a couple of times blepharospasm, and so this person wants to know that she says her husband spends many hours with his eyes closed.
Yes.
But he's not asleep.
Yes.
So I know you mentioned like the dry eyes and the blinking. So can you discuss a little bit more about that particular type of dystonia?
100%, definitely. And that's very common. This is typically seen in something called progressive supranuclear palsy, or PSP. And it's called apraxia of eyelid opening. And you'll notice sometimes, I'm sure you'll notice your husband can open his own eyelids with his hands, and he'll use his fingers to open his eyes. This is one of the greatest experiences in my life, is injecting for that, because right there and then, I don't even know if it's the toxin that works or if it's more of the sensation of being poked that stimulates a response. But I've seen just hundreds of times, people will right away open their eyes after the injections, and it's really lovely. You hear sweet things like, "I see you again, honey," and it's beautiful. So please look into that.
Awesome. And so someone just wrote in about their son had Botox in cheeks for drooling, and it helped. No notice of change in getting up and staying with Botox in ankles. But another person said, is there any contraindications for using oral baclofen regarding sialorrhea?
Baclofen is not going to treat sialorrhea. Baclofen is used for spasticity, and so it doesn't even have a side effect profile that would stop it from stopping drooling. Technically, Artine or trihexyphenidyl, because of one of the side effects is dry mouth, that can actually help more with the drooling. I would rather get injections personally. If it was my family member, I'd say just get injections rather than taking a medication having side effects.
And regarding the face. Someone had asked, I gotta find the question. Does this work for when your upper lip looks like it is locked up, which makes it hard to speak?
Yes, the upper lip is one of the danger areas to inject though. And so you really need to use a very, very, very low dose because it can get weak very easily. And then it becomes stuck and you become an actor who you can tell has had Botox.
All right. And then we had a couple of questions. And regarding the lower limb dystonia, someone had used it. They said that it worked really well, but their insurance didn't want to approve it. And then another person wanted to know, how much does an injection cost? So is it vary? And can you talk a little bit about how insurance does cover that, or Medicare?
Yes, relevant, important, very pertinent. And so this is the number one thing is Botox itself. The botulinum toxins are extremely expensive, unbelievably, ridiculously expensive, up to $5,000 for a small vial. And so insurance covers all of it. Insurance should cover all of it. And so especially if you have Medicare, you can inject right away. You don't even have to run it through insurance. You can just go ahead because Medicare will cover it. You have to make sure it's an FDA approved condition. The lower limb dystonia is typically covered. There's coding mechanisms, none of which are illegal, but there's spasticity and dystonia often go hand in hand. And so it's FDA indicated for spasticity. Dystonia is technically off label, but they're really the same thing. They're overactive muscles with rigidity. And it's the same. And if you talk with a peer-to-peer, one of the insurance companies, and I've done this several times, they understand. It's you know, our goal is to help you. So yeah, it should be covered by insurance, all of this.
So if it's not, someone's having an issue with that, it could potentially be a coding issue, and they might want to go back and ask them to resubmit with a different code potentially.
Yes, and your physician should do that for you.
Great. Another person wrote in about the curling of the toes being on one foot and wanted to know if carbidopa-levodopa actually can cause that to happen, because it started after they started taking carbidopa-levodopa.
Very interesting. I have this conversation every day. So there's two different conditions here. There's dyskinesias and dystonia. So let's think about a line. I'll try to just give you a visual. So a flat line here. If you're below the flat line and you have too little dopamine, you're going to get slow, stiff, shaky, and can't walk. If you're above the line, have too much dopamine, you're going to move too much excessively, and involuntary movements, kind of writhing, choreiform movements. And so it depends in this person's situation. Sounds more with the toe cramping is typically an off phenomenon. So it's usually when the carbidopa-levodopa is wearing off. I understand time-wise, it seems that the carbidopa-levodopa started it, but chances are the medication's working, helping, and if you did not take it, you'd have this all the time. And so I think the medication is helping relieve that rather than causing it. Sounds more like a dystonia. I probably would go for the injections for this.
Great. And I'm glad you talked about dyskinesia, because there was another question about whether Botox could treat dyskinesia.
Great question. And if you saw on the slide, there was actually one of the indications for movement disorders for injections was levodopa-induced dyskinesia. I target the problem. I like to go for what the real problem is. A levodopa-induced dyskinesia is over medication. And so I'd rather reduce medications than inject and do something else. But that's just my personal practice style.
All right. So this person said, I tried Botox unsuccessfully, or botulinum toxin. It may not have been that particular one, for foot cramping dystonia, 4 treatments, 3 months apart, no success. I've even had injections in the bottom of my foot the last 2 times with no improvement. I've stopped the treatment for 6 months. Is it worth revisiting?
The only way I would revisit that is if I would try a different formulation. Because obviously with the formulation you had, either Botox or Myoblock or Dysport or Xeomin, that it wasn't working. And so that could be that just that one type doesn't work. There's a couple ways to do this. You can inject until it causes weakness, which I don't think is a prudent plan. I personally would probably try oral medications at this point. I mean, this is 4 rounds of injections. The bottom of the foot, I stopped doing it because I had a nonverbal patient scream because of the pain. It was like stepping on a nail. I'm not here to hurt anybody. So I just avoid that. And for this person's situation, I'm not the physician. I will give that disclaimer, but I would probably use baclofen or trihexyphenidyl.
Great. All right, so here's another one. This person's had 2 sessions of Botox for curling toes, for turning inward, no relief. After first session, after second session, still have painful curling of toes, and a month out, I have weakness in my legs, ankles, and feet. The
Yeah.
weakness seems to be improving slowly. Is this temporary?
Temporary, definitely temporary. That's the good thing about all of this. Good and bad thing. You have to keep getting injections because it's temporary, but also there's not going to be side effects for that reason that will last forever. So that's temporary. It's difficult though, and be very careful if there's difficulty. Excuse me. Pushing off with your toes, then you should get an orthotic, and because you'll fall otherwise. You need an ankle foot orthotic to make sure that your foot isn't dropping. Otherwise, it's going to slap the floor. You're going to catch it and fall. So just for a month or two, I would get that to be safe.
All right. This person said, my wife has Parkinson's and now suffers from back muscle spasms. She had fallen years ago, which might have contributed. She's had Botox, but it didn't seem to work. Is it possible it just wasn't injected properly?
Yes, 100%. And it's possible it was also done gently, that they underdid it and on purpose, and just to make sure. I had one person just have a very unusual response to the injections. And this is full honesty, is their hand just ballooned up. It was what happened for 3 or 4 days after the injections went away. And it was just unusual. You never know what your response is going to be. So go low at first. The tangent to the point of the story is make sure that at the low doses, it's not going to cause problems. Try it again the second time once it's safe. And if you go back to that little algorithm, if you've tried one dose of injections, have not had any side effects, increase the dose with the second set. Not to the point you have side effects, but to get a better response.
Great. And I know you sort of mentioned this earlier in the presentation, but we had a comment that asked if you could comment on common frequency of injections. And does it vary by where you're injecting?
Well, it should be every 3 months only.
Okay.
Don't do it more frequently. Again, you'll build a resistance, but also you get side effects. It's wanting to go from 80% to 100% that gets you in trouble. Trying to shoot for that perfection usually causes some side effects. Take the improvements, be happy, live with it, and know what it's like to not have it rather than causing problems.
Great. And you did say that it could eventually get to the point where it's not as effective. And is there like a certain timeline, or is this vary by person?
I'll be honest, I've never seen that happen. Okay. I've had somebody inject for 15 years. I've not done all this. For 7 years, I injected it, and they had it for 8 years before me. Actually, I think even longer, and never had a response like that. This is theoretical. So don't worry about that. Just keep it safe every 3 months, and you should be able to go for decades.
So it's curious, like there's a lot of people that have symptoms that seem they would be appropriate for it, and yet haven't actually had it done. So is there a reason that neurologists or movement disorder specialists aren't maybe bringing it up? And do you have any recommendations for people to bring it up?
Yeah, definitely bring it up. This is the reason I wanted to give this talk. Is everywhere I've gone, it's like, wow, I didn't know I could treat this. Wow, I didn't know I could treat this. And yeah, you can, and it's fairly safe and fairly easy. It's not a medication every day. There's a psychological trauma to taking too many medications every day. I've seen, my people with 30 medications, and you don't need another pill. You need less pills. And so this is one way to get around that, to actually treat the symptoms without the trauma of the overburden of medications. Ask your movement disorder specialist. If you're not seeing a movement disorder specialist, find one. They should be able to give the injections, or know of somebody who can.
Right. And someone wanted to know if you've ever seen a non-reversible negative effect.
I saw that question. No, I have not. I have not. Let me think. Actually, I can theoretically say I have not had this happen myself, but I could see that if you did over-inject in the neck, and cause swallowing problems, it could cause pneumonia or something serious, dangerous that could be life-threatening. So I want to cover every aspect of this and not just make this a pro talk, but talk about pros and cons. The potential is that this can be dangerous, especially if you overdo it, and especially in the lower part of the neck. The rule of thumb for the neck is if you stay high, away from the swallowing muscles, and you don't over inject, that you're going to be fine. There should not be any complications.
All right, so another person just wrote in, Parkinson patient, very specific pain origin in suboccipital area, causes intense headaches that travel throughout head. Who would they look to as an injector?
That's very interesting. So yeah, I know someone in my family who has this right now. And it's probably occipital neuralgia. It's probably irritation of the nerve in the back of the head that's causing this. And typically for those you do, they're called steroid. They're steroid injections, basically. And you take a Kenalog and you mix it with something called triamcinolone, and you can inject that with saline, and it's effective. Botox, they actually have done studies for occipital or episodic migraines, and it's not as effective as the, I'm blanking on the specific name for those, trigger point injections, excuse me.
Great. And I know you mentioned it, the injections for the bladder are done by the urologist, and that is actually something that I've known people to do successfully because there are side effects to some of the medications they take for urinary issues.
Yes.
So is that something that, just so people understand like the process, so that's something that is identified from the movement disorder specialist, and then they kind of help them to find the right urologist to do that? And is that, what kind of success rate do you see or know of in terms of addressing those urinary issues that way?
Very good question. And so I'd say probably about 50% efficacy sometimes. And it's either kind of, it's a black or white response, either yay or no. It just does not work. There's not really a middle ground where it kind of works. And the medications, they're oxybutynin is the notorious one that causes confusion and the balance fatigue side effects. It's got the anticholinergic properties. There's a newer medication called mirabegron. I don't make names, Myrbetriq, and that one actually is less cognitive side effects. From our standpoint, it's funny. If you go to us, we're going to say no. Movement disorder specialist, no. The overactive bladder is something else. Typically, if it's not related to Parkinson's, it's an atypical Parkinsonisms that can cause it. Urologist will say no. It's the neurologist who. So you'll hear that, and I apologize. I think a urologist, and you definitely, I don't know any movement disorder specialists who inject for overactive bladder. I would go to urology for that.
Well, I'm glad that you mentioned that, because I think that's where the person and the care partners get stuck trying to navigate this. One person say no, the other person say no, it's the other one, and they're left in the middle trying to navigate that. So it's helpful to have that discussion and bring that up.
And that's why we have the PMD Alliance, to fill these gaps and help our oncologists. Yeah, this is the purpose. So thank you.
Absolutely. Well, we do have a couple more minutes. If there are any other burning questions that we didn't get to, I know Dr. Bluett has really covered it very holistically. So you might have actually answered all of the questions, but I'll give them another second. And I didn't know if there was anything else that you wanted to add to the conversation that we may not have touched on yet, or want to expand further.
Yeah, I say this for every presentation I give. Remember that this is your body. You have to be your own medical advocate, unfortunately, in medicine. And you just have to bring your own problems up. The doctor's not going to cover everything. And so come prepared, get what you want from the visit. If you don't get what you want from the visit and the doctor is not amenable to changing, then you need to find a new doctor. This is about you, not the doctor. Okay. So remember that this is about you, not us.
Oh, we did get a quick question because you mentioned head drop earlier. What they want to know, what the longest you've seen this last.
3 months. 3 months is the longest I've seen it last. And yeah, you have to get a neck collar. It's not fun. It's not great. But yeah, I literally, I think I've had it 4 or 5 times over about 1,000 injections. Should not happen if you are very cautious with the injections.
Awesome. All right. Well, there is another one. Is it common for Botox injections to not last as long as you do more of them after about a year. I find the injections in my foot or calf now only last 4 to 6 weeks.
Yeah, and you're going to need a little bit of a higher dose, and you're developing a tolerance, and you can also switch the formulation as well. So if you can go back, let's say you go to start off with 60 units of Botox, and then you go to 80 units, then 100 units, and 120, and you're finding it's not working. Try Dysport. Dysport is actually lasts longer technically.
Awesome. And somebody wanted to know about research to pursue for Parkinson's. Actually, you can find open research through clinicaltrial.gov, where they are, whether it's related to botulinum toxin injections or really anything that is being done. They'll give you the sites, the site coordinator. You can also register with Fox Trial Finder and get a profile on there, and they will link you with research trials that would fit your profile and where you are within your disease state and your medications and all the things that they use to determine inclusion and exclusion. So Kelly just put the website for clinical trials up, and I really am so thankful, Dr. Bluett, for you having this discussion, because I don't think that we've ever really had one focused just on botulinum toxin and all the different movement disorders and indications for it. So it's really good. Someone wanted to know if you're involved in any clinical trials.
Mr. Cox, great question. I see that. Thank you for asking, because that's the purpose of this organization. I'm starting off just practicing, but I want to start clinical trials here. That'll be coming in a couple of years.
Awesome. So stay tuned, because we will probably let you know when those happen. So awesome. Well, Dr. Bluett, I want to thank you so much for joining us today and giving us all of this fantastic information. And I want to thank everyone who joined in and hopefully came away with lots of really good information and know how to have this discussion with their physician. And maybe if they have been on the fence about whether they should try it, now they feel they're armed with the information to go and have that discussion with their doctor. So glad you joined. So there's a tradition that we have with our online programs as we thank our wonderful speakers such as yourself for being a part of that. And is our wave of gratitude. So I want to invite all of our audience to give Dr. Bluett the wave of gratitude. Let him know how wonderful he was and all the awesome information, and wave to yourselves, because you are all awesome too.
Yeah, I
It's
agree.
always so great to see your faces. It makes my day, and it makes all of us at PMD Alliance's day. So thank you, Dr. Bluett. Thank you. All
You guys are lovely. Thank you so much. I appreciate it.
right. Have a wonderful day, everybody.
Bye.
Bye.